Okay. So this is Ohio Notes. Ohio Notes is going to be your best friend until the day you die, probably. Actually, I don't know. Ohio Notes is amazing. I absolutely love Ohio Notes. I mean, it's just something else about Ohio Notes. That's amazing. Um, so just please know like simple stuff. Like if you don't know this, why are you even taking APMLE Part 1? Know the regions, what they're called, and what they're like. So the like knee is obviously the knee, thigh, femoral, gluteal, hips, or hip or coxal region. That's simple, layman terms. This is for you. The extensor surface of the lower extremity is anteriorly displaced, whereas the flexor compartment or flexor muscles are anteriorly displaced on the upper limb. So flexors are anterior in the upper limb, extensors are anterior in the lower limb. Know these, like these are just like this is for like what? Like why don't you know that? This isn't hard stuff, people. I mean, you should get like watershed area. So the watershed area is actually there because the calcaneus tendon, the calcaneal tendon, the Achilles, whatever you want to call it, it's very posterior. So for a blood vessel to get there is kind of rough. So that's why it's actually a peroneal perforator and a posterior tibial perforator. They anastomose very, very scarcely in an area right here. So, like, I don't know. Let's like friggin' draw. I don't know. I feel like drawing. Oh my god, you gotta be. Oh, I didn't even select something. So, imagine the posterior tibial is running down here, and imagine the peroneal is running down here. There's a communicating branch that's like communicating, obviously. The communicating branch that like just scarcely supplies um, the calcaneal tendon. Also, question for everyone: what is the name of the sheath which covers the Achilles tendon, which is not seen in any other tendon? It's not a synovial sheath. It's a peritoneum. The calcaneus, the calcaneal tendon, the Achilles tendon, has a peritoneum. Also, I'm just going to put here one more thing, which I think, I mean, it's a board question. I mean, you're going to be asked this. Gastroc is, oh my god, you got to be kidding me. Gastroc is to now options. Is it lateral, medial, superior, or inferior? I guess I'm just giving everyone time. I don't know how to answer this type of stuff. So what are the actions of the calcaneal tendon? Right? Anyways, moving on. Can't seem to find the answer to that. I forget, actually. Oh my god, you have to know this. Please, just know this. I mean, why wouldn't you know this? Okay, dorsal venous arch. Now, know that the great saphenous vein anterior to the medial malleolus, the termination of the great saphenous vein is the distally is the medial marginal vein. Medial marginal vein is seen dorsal and medially on the big toe, the hallux. There's the dorsal venous arch. Dorsal venous arch divides into 4 veins, which is the common dorsal metatarsal. You can call them dorsal metatarsal veins, 1 through 4. 1 being most medial, 4 being most lateral. These dorsal metatarsal veins divide into proper dorsal digital veins, right? 1 through 8. So that is seen. Dorsal veins, for example, proper dorsal veins 1 and 2, they're seen right there. Oh my god, this is another. It's like my 13th reason. Anyways, So yeah. Yeah, so you have this right here. You have vein 2, vein 3, you get the point. Lateral marginal vein. Lateral marginal vein, you see how it goes posteriorly. So you see how this vein is going to go posterior to the lateral malleolus. It's actually situated not just posteriorly, but inferiorly to the lateral malleolus. So great saphenous vein, anterior. Great saphenous vein, anterior to the medial malleolus, ascends upwards. Great saphenous vein, stays medial, goes up, drains into the into the saphenous opening, into the femoral vein. So this drains dorsally, right? Dorsally, and then the lateral marginal vein combines with the small saphenous vein, right? This is called the lateral marginal vein. So the lateral proper dorsal digital vein and the dorsal venous arch form the lateral marginal vein, which continues as the small saphenous vein. The medial proper dorsal digital vein, right, is this one right here, which is a termination of the great saphenous vein, combines with the dorsal venous arch, forms a great saphenous, draining into the femoral vein. So now let's just do a problem. Now, lymphatics from the medial side of the toe are going to go upwards, right? They're going to go proximal. Veins in the foot are going to go proximal. Another special thing about venous system in the foot is it drains from superficial to, it drains from deep to superficial, unlike the rest of the body, which is superficial to deep. So that's just an interesting point. Just know that, I guess. And obviously here you have the vertical superficial inguinal lymph nodes and the horizontal superficial inguinal lymph nodes. Horizontal group is going to drain the inguinal region, along with the buttocks, the lateral, lateral upper buttocks and stuff like that, like the gluteal region, and the iliac region. Roughly, that's what it drains, and the genitalia. Actually, that's important. And the genitalia is drained by like the vulva, the penis, vaginal, all that stuff. Vertical group of superficial lymph nodes. The best way to remember it is it drains everything the great saphenous vein drains. It's going to go, you see, it stays medial, starts off a little anterior, goes medial, goes all the way down, goes posterior to the medial femoral condyle, actually. And that's actually an important thing to know, I'd say. It starts off anteriorly, goes medially, goes posterior to the medial femoral condyle, comes out anteriorly, just distal to the medial tibial condyle, and it comes out, goes all the way down. And actually, in someone more vascular, you can see the great saphenous vein draining. Now, let's just do a quick review of this right here. Vertical group superficial inguinal lymph nodes. You're going to have draining everything the great saphenous vein drains. Now, someone has inguinal lymphadenopathy, right? And they have a puncture wound to the medial dorsal second toe. Now, why do you see inguinal lymphadenopathy? Why? Because it is this is the watershed area, people. I mean, like roughly, like I'd say right here, it's like a watershed. Anything like to the right of this, right? Anything more medial is going to be drained by great saphenous, draining into the femoral. Femoral that will deposit into the inguinal lymph nodes. And because of that, you'd have inguinal lymphadenopathy, swelling of the inguinal lymph nodes. Now you have laterally, on the lateral side of the pinky, or on the medial side of the fourth toe, right? You have antigens, which would be carried to the popliteal lymph nodes, which I think is next. You have a freaking cut on the right side of your foot, right on the lateral aspect of your fourth toe. It's going to be carried into the popliteal lymph nodes. You're going to get popliteal lymphadenopathy. The popliteal nodes will carry that first. Those are going to drain into the inguinal lymph nodes. Okay, know this, please. I mean, like, lymphatics is so important. I mean, it's just so frustrating. No one knows this stuff. Saphenous opening. Now, question: what's the lateral opening, lateral margin of the saphenous opening called? Cribriform fascia. Good job. Now, what is the fascia? Damn it, I gave it away. What is the name of the fascia covering the saphenous opening? Good. Cribriform fascia. Right? and lateral margin of saphenous opening is called the falciform margin. I don't know if I said that. I don't know what I said. Okay, moving on. Know this like the back of your hand. First web space is going to be deep fibular nerve. Deep fibular nerve is the first web space. Medial malleolus, medial calcaneal nerve. Lateral malleolus, superficial fibular nerve, right? Some people actually say the medial malleolus would be the saphenous nerve. I'm not here to argue. I'm just here to say the facts. Medial anteromedial leg is going to be saphenous. Anterolateral leg is going to be the lateral sural nerve, or you can just say sural nerve. Anterior thigh is going to be majority femoral nerve. This is not actually the best representation. I'm not going to lie. Lateral thigh and upper and lateral thigh is going to be to the mid thigh region. Is lateral femoral cutaneous. This is coming way too far down. It doesn't really come. It ends like right here, I'd say. So like up until this portion. Oh my god. This so up until here, it's lateral femoral cutaneous. Now, is lateral femoral cutaneous, is it dorsal division or ventral division? It's dorsal division. Dorsal division, ventral rami of L2 to L3, right? Subcostal nerve innervates the smallest portion up here. I think this is showing way too much. It does not come that far down. Femoral branch, genital femoral versus genital branch of genital femoral. Now, does anyone know the cremaster reflex? Cremaster reflex is when you palpate and touch very briskly the upper inner medial thigh, right, to initiate the ascent of the testicles to make sure that the cremaster muscle is contracting properly, which is within the lining of the scrotum. Right? I think I'm right. Yeah, cremaster. That is cremaster. Cremaster, yeah. It helps the ascent of the testicles, right? So the genital branch of the genital femoral is going to be the afferent limb of the cremaster reflex. Yeah, the genital femoral. Because it's sensory, right? That's I doubt that on the APMLE did ask that. Saphenous nerve, it's going to be important for the rest of your life. Very important. It's medial leg, almost to the ball of the foot and medial arch. So I don't like these diagrams for a few reasons. They're kind of annoying. You gotta be kidding me, man. Can I not move on? Okay, thank God. This is a little better. I love this. This one's good. Now, I can spend at least an hour on just this one. This page. It's very dense. Why? Because just so much going on here. Oh my god. Am I blocking? Is my freaking thing blocking? You gotta be kidding me. I also don't want it displayed 2 pages. I want it single page. Thank God. Okay, this is a little better. Okay. Now, cutaneous nerves of the posterior leg and thigh. I mean, I can go on about this forever and ever. Let me just. Okay. Posterior thigh and leg. It's going to be saphenous nerve, majority of the medial leg, from the medial condyle tibia region down to the medial malleolus. Know that saphenous is medial. Lateral is lateral cutaneous nerve of the calf, or it's a branch of the. It is the lateral sural, also called. It's a branch of the fibular division. It's a branch of the common fibular nerve. And so it's actually really interesting what you see right here. What you see right here, you see this red, the saphenous nerve, right? So this red, which is the saphenous nerve, it's actually interesting. It innervates it actually skips a portion right here. And that's because the sural nerve gives off the lateral calcaneal nerve, right? Whereas the medial calcaneal nerve is given off by the posterior tibial nerve. The tibial nerve. So that's the difference. And that's important, I think, just because it's 2 adjacent nerves which are originating from 2 different locations. One is sural nerve and one is the tibial nerve. Tibial nerve gives off medial calcaneal, whereas the sural nerve is given off by the the lateral calcaneal is given off by the sural nerve, right? So those are two terminal those are like one of the last branches of both those nerves, medial calcaneal and lateral calcaneal. They're adjacent areas. Also, this is not like properly displaying. Medial calcaneal dominates the innervation of the calcaneal region. So really, when you like at heel strike, it's really the medial calcaneal nerve which is giving that afferent sensation, like somatic sensation when you hit the ground at heel strike. Kind of important, maybe a word question. I don't know. Who knows? No one knows anything. Iliohypogastric, really high nerve. It is after the subcostal, it's like the second nerve in the lumbar plexus. So know that it innervates a very, very superior region of the gluteal region, almost like the lower back, because it's L1. I mean, that's pretty high. Now, middle cluneal and superior cluneal, just note that they're both dorsal rami, whereas the inferior cluneal is actually a branch of the posterior femoral cutaneous nerve, right? So also supplies some to inferior. This is I'd say this is incorrect. Ohio notes is Ohio notes. I mean, it's from Ohio. What can you do? Posterior femoral cutaneous is really the giant innervation on the posterior aspect of the thigh and knee. It innervates the skin over the pop fossa, okay? Medial femoral cutaneous, right? It's on the medial side. Obturator nerve, medial side, medial upper thigh region, where like the adductors are, right? So some of this is really self-explanatory because the nerve that's innervating the region also usually will innervate the muscle, right? So for example, femoral is anterior thigh. Femoral is also innervation to the anterior compartment of the leg. Tibial nerve, right? Tibial nerve innervates through its two terminal branches, medial and lateral plantar. Through medial and lateral plantar, the medial and lateral plantar, it innervates the whole sole, the plantar aspect of the foot, and it also innervates indirectly innervates all of the cutaneous and the foreplantar muscle layers, all through the tibial nerve, right? So it makes sense. It's all methodical. Saphenous nerve. So some are solely cutaneous. I think that's also important. Some nerves are also solely cutaneous in the lower extremity, right? Inferior cluneal, iliohypogastric, right? Dorsal, middle cluneal, superior cluneal, and inferior cluneal, cutaneous nerves, no motor sensation. Obturator nerve, it's a mixed nerve. Why? Because it innervates the medial compartment along with the medial upper thigh, medial femoral cutaneous, lateral femoral cutaneous, posterior femoral cutaneous. Saphenous nerve, lateral cutaneous nerve of calf. These are all cutaneous nerves. They have no innervation to muscle. Medial calcaneal, lateral calcaneal. These are all branches of the cutaneous nerves. These are all cutaneous. There's no muscular innervation by any of these nerves. You don't get muscular innervation until the very last end right here. And so the thigh is actually innervated. The posterior muscles, right? So the posterior compartment is innervated by the tibial and the sciatic nerve via the tibial and common fibular divisions of that nerve. The posterior compartment and the deep posterior compartment are innervated by single nerve, tibial nerve, right? Common fibular nerve takes a detour, goes posterior to the neck of the fibula, goes anterior. So it then divides into superficial and deep fibular nerve branches, right? Which we will get to. Know this 100%. Oh my God, I love this type of stuff. Superficial fibular nerve is going to emerge more anterolaterally. It's going to pierce the fascia, the crural fascia, and emerge. Deep fibular nerve actually embeds itself into the deep fascia until emerging again. And so it emerges right here in the first interspace. And so the cutaneous sensation of the first interspace is that. Saphenous nerve, as I said, it comes past the medial malleolus along with the great saphenous vein, which travels like such with that saphenous nerve. And it innervates just, the medial arch, medial malleolus, almost to the ball of the foot. Some people say saphenous nerve innervates. Who knows? Who knows anything? In lab, you probably saw superficial fibular, and then it divides into its two terminal branches. which are the medial and intermediate cutaneous dorsal cutaneous nerves. Easily palpable? Who knows? Medial dorsal cutaneous, I don't know if it aids in supply of the first web, but one thing that's important is the medial proper dorsal digital nerve, right? That's what this is. Medial proper dorsal digital nerve is this right here. It's this. This right here is the medial proper dorsal digital nerve, coming from the medial dorsal cutaneous nerve, coming from superficial fibular nerve, coming from common fibular nerve, coming from the sciatic nerve, right? So it's, you trace it all the way back, you know, see where does it come? Where does it come from? This is all sciatic. It's all sciatic. No one uses this name. I don't even know who the hell that is. These are proper dorsal digital nerves. Anything innervating the interspace or the medial and lateral of the big toe and lateral fifth toe, respectively, that is called a proper dorsal digital nerve, right? That's why it says proper, because they're proper. They like being in a specific spot, so they're proper. Now, common digital nerves are the proximal counterpart to proper, so they're common, right? Which is weird. They're not common. There's actually fewer common dorsal digital nerves than there are proper dorsal digital nerves. It's weird. Think of a popper. There's more poppers than there are commoners. I don't know. Do with that information what you want. So that's that. This is the dorsal innervation. Sural nerve coming laterally, posterior and inferiorly from the lateral malleolus, coming and emerging from right around the fifth metatarsal tuberosity, the styloid process of the base of the fifth met. Coming dorsal and innervating laterally on the fifth ray, basically. That's what it innervates. So this is the dorsal innervation. Intermediate, remember, intermediate is going to innervate the third and fourth web spaces. So intermediate is 3 and 4. Medial dorsal cutaneous is just one whole interspace, and the medial of the dorsal medial of the big toe. So again, medial dorsal cutaneous, intermediate, the medial of the big toe, the dorsal and medial of the big toe, the dorsal, medial, and lateral of the second digit and the third digit. Intermediate dorsal cutaneous is going to come down. You're going to have this branch. It's going to divide into 2 common dorsal digital nerves, right? And then it's going to divide further into proper dorsal digital nerves, 6, 7, 8, and 9. So it has 4 proper dorsal digital nerves, whereas medial dorsal cutaneous is going to have 3 proper dorsal digital nerves. Deep fibular nerve has 2 proper dorsal digital nerves. So deep fibular gives rise to proper dorsal digital nerves 2 and 3, right, respectively. Medial dorsal cutaneous nerve is going to give rise to proper dorsal digital nerve 1, 4, and 5. Okay. Now, the intermediate dorsal cutaneous nerve is going to give rise to common dorsal digital nerve 2 and 3, right? Those divide into 4 more nerves, right? That goes down to common dorsal digital nerve 6 and 7, and proper dorsal digital nerves of the intermediate branch of the superficial fibular branches 8 and 9, right? And lateral dorsal nerve or lateral dorsal sural cutaneous, I don't know, gives rise to proper dorsal digital lateral proper dorsal digital nerve, number 10, right? So just know this stuff, man. Know it like the back of your hand. There's no one who's a better lower extremity specialist than a podiatrist. See what I'm saying? Listen to me, man, please. Also, it's kind of cool they made this one thicker, because I think that is the one that's thicker. There's a better animation later that goes over, but lateral calcaneal nerve. Lateral calcaneal nerve, sural nerve gives off the lateral calcaneal nerve, whereas the medial calcaneal, it's not showing here, it's given off from the tibial nerve, right? So this actually shows it a little better. So the medial calcaneal nerve really innervates up until like here. Oh my god. So the lateral medial calcaneal nerve is actually like up until here. So like, oh my god, what's wrong with me? So like really until here. So like all the way, so like this whole portion is medial calcaneal. It's a smaller portion than this, which is the lateral calcaneal. So we're just gonna end with I don't like this one, honestly. This is not clinically relevant. And I'll say a few things on that. This is more like textbook definition. But what you see clinically is not these dermatomes. What you see clinically is this. No, not this. They don't even have it here, bruh. Oh my God. This is not like what I like, honestly. This is good. Myotomes, yes. So I'm going to end at myotomes, and then I'm going to make a separate video for osteology, gluteal, and yeah. So yeah, okay. So the retinacula, lateral view, ankle. So the fibular retinacula, I mean, it has an insane amount of attachments. Like some people even say like tarsal sinus is like an attachment, and origin. Let's see what even the origin is. So it says here, superficial fibular peroneal retinaculum formed by fascial creux, holds the peroneal tendons down and creates a pulley at the lateral malleolus. That's true. Both are in a single tendon. What's the tendon? It's a tendon sheath, and pass deep to the retinaculum. Yes, true. So you see the peroneals. You're going to see them coming down all the way here. This is superior peroneal retinaculum, inferior peroneal retinaculum. Anteriorly, you're going to have the fibularis brevis. Inferiorly, you're going to have the fibularis longus. So that's actually important. I'd say that's important. They are in a single tendon sheath up until here. They're in a single tendon sheath here. They divide their sheaths right around here. Like right around here. Like as it passes here, they've already separated their tendon sheaths. So single tendon sheath. So single tendon sheath here. And they have individual tendon sheaths right here. They have individual tendon sheaths right here. So by this point right here at the inferior extent of fibular retinaculum, I don't even know. It's just call it the dorsal fascia of the foot. I mean, it does not need to be fancy. No one cares. It does hold them down, you know, because when it pulls, right, if you didn't have these retinacula, the tendons would just be loose and floppy, right? That's really the point of these retinacula. I have never heard it been called the extensor annular ligament, but just know, I mean, Ohio Notes is good. I mean, no way, in no way, shape, or form. Also, no one has actually, yes, I actually have heard it been called the fundiform ligament. I thought it was called the fundiform, but so you see this right here. This is the fundiform ligament. This lateral portion of the inferior extensor retinaculum, that is called the fundiform ligament because it forms the stem of the inferior extensor retinaculum. So some people, it says in the notes here that some people say that it's continuous. The inferior fibular retinaculum is continuous with the stem or the fundiform ligament or the lateral portion of the inferior extensor retinaculum. Some people say this. I've been going on for 34 minutes and I feel like I'm wasting my life right now. I'm just going to go a little bit longer and then that's going to be it. Medially, what do you see medially? Also important. I mean, how the hell can I forget it? Inferior extensor retinaculum. So there's actually two things that pass under the stem. So there's two groups of things which pass under. There's things that pass under the superomedial and inferiomedial oblique. So these are this is the superomedial. This is the inferiomedial oblique bands of the inferior extensor retinaculum. So what passes under the bands is going to be the EHL, extensor hallucis longus, tibialis anterior, the dorsalis pedis, and at that point, it's termed the deep fibular nerve. They're going to pass deep to the bands. Now, what's going to pass under the stem is going to be, it's actually not even pictured here. It's going to be the EDL right here, and it's also going to be this right here, which is it's going to attach right there. The fibularis tertius, right? That's going to attach right at the dorsal base of the fifth metatarsal. So you have the EDL and the fibularis tertius attached, going inferiorly and going to go run underneath the band, the stem of the inferior extensor retinaculum, whereas the superior-medial and inferior-medial oblique bands of the inferior extensor retinaculum, that's going to be the nerve and vessel, which is the dorsalis pedis, and the dorsalis pedis is the terminal branch of the anterior tibial artery. And then you have the tibialis anterior, extensor hallucis longus, which and the anterior tibial artery, dorsalis pedis artery, and the deep fibular nerve. They're going to go deep to these bands. Yeah, no. Last thing, actually, I'm not going to go over those dermatomes because I don't like how they look. I'm not a fan of them. Now, Tom, Dick, and Harry, just please remember this. This is the flexor retinaculum, or also, yes, it is called the laciniate ligament. I have heard this. Oh my God, it's not in a straight line. It is a thickening of the. It's a thickening. Okay, I guess it's a thickening of the crural fascia. Yes. Netter's anatomy shows this way better than this is showing, but it's continuous with the crural fascia, the deep fascia of the leg. It's crural. It's continuous with the dorsal fascia of the foot, and it's also kind of attached and continuous with the plantar fascia. Sure, it does hold the flexor tendons down of the foot, and it creates a pulley. Yes. Why? Because it's, I mean, like these tendons and vessels would all be floppy. So what this is showing is this is the TP, the tibialis posterior. This right here is the flexor digitorum longus, and this right here is the flexor hallucis longus, right? So Tom, Dick, and Harry, right? But it's Tom, Dick, and very nervous, right? So let me just change the color of this. So let's just call it. So let's just say that for the time. So this is the neurovascular bundle, which runs in between flexor digitorum longus and flexor hallucis longus. Flexor hallucis longus is so posterior that it goes in between the two tubercles of the talus, the medial and lateral. Yeah, so that's how far back and posteriorly oriented that is. We're just gonna move on to here. Know this because actually I was doing board vitals, and one of the questions I was asked was something so random, which is like, what's the free edge? And it's called the hyponychium. The free edge, or this area right here, the hyponychium, proximal. So hyponychium, eponychium is proximally. Cuticle is that area which is adhered to the proximal portion of the nail. The lunula is that little crescent you see on the proximally on the nail. The nail matrix actually produces the nail. Right, and the nail matrix is actually attached to the base of the distal phalanx. What else? Nail plate, nail bed. Anchor the nail plate. Sensory innervation to the nail bed is variable and maybe entirely from the proper digital plantar nerves or from plantar dorsal and proper digital arteries. Therefore, you must take procedure. Boring. I don't like that. I don't like that. Myotomes. Myotomes are so important. Actually, I don't know. I don't even know if they're important or not, but for exams at school, they're important. So basically, my point in saying of the myotomes is there's no easy way to memorize them. Just memorize them. Just sit and do them. I mean, there's no other thing you can do. So you have the hip. So always look at it this way. I always did it this way. L4, L5, right? So inversion, eversion. Inversion, L4, L5, right? So imagine this is my foot, right? So subtalar joint, inversion versus eversion. So L4, L5, L5, S1, right? And imagine this is dorsiflexion and plantar flexion. Now, dorsiflexion would be L4, L5, S1, S2, right? L4, L5, S1, S2. Now, because the toes are more distal, it's going to be a more inferior spinal segment, right? So dorsiflexion and plantar flexion of the toes is going to be different. So imagine this is dorsiflexion of the toe and this is plantar flexion of the toe. So dorsiflexion is L5, S1, S1, S2, but it's really, that's not true. That's not true. It's really S1, L5, S1, S2, S3. So it's L5, S1, S2, S3. This is incorrect. I don't agree with this. I personally don't agree with this. This is correct. L5, S1, S2, S3. But who cares? Who cares? Now, yeah. Patellar reflex, know that. Very important. The plantar flexion reflex is going to be tested by, it's going to test S1, S2. Patellar reflex extension, it's going to be L2, L to L3, L4, right? Flexion of the knee is going to be L3 to S1. I don't even know. Like, the thing with these myotomes is, like, it's so variable and it's so different in any textbook you see. Like, who even knows, right? Like, for the exam purposes at any school you're at, just follow the myotomes they say to follow. But in clinical relevance, it's like, who even knows, right? Extension of the knee, extension of the hip. That's actually really neat. So I'd say the very valuable information is right here, actually, because this groups together three motions, right? L1, L2, L3, L4, flexion, adduction, and medial rotation of the hip. So if you flex, adduct, and medially rotate, and that would be L1, L2, L3, L4. If you extend the hip and you abduct the hip and you laterally rotate the hip, right? You'd be doing L4, L5, S1. That's cool. That's cool. This is going to be in a different video because I don't want to do this anymore. I'm not going to lie. Okay, well, I hope this helped for the very generic. So this is so this is going to be titled the Cutaneous Innervation Introduction to APMLE Part 1 Lean. So that's what this is going to be. Anyways, hope everyone does well on this. I don't know. Okay.